was laughing and had developed what became a long-lasting relationship with Charlie for our organization. Charlie's had very close relationships with physicians in the Lehigh Valley ever since he first ran for the state legislature. So he became friends with our group. Many years later, one of our members, who happened to be the president of our group the day that Pearl Harbor was attacked.
9/11.
No, exactly. No. Let me tell the whole story. This lady was turning 100, but she was president of our organization the day that Pearl Harbor was attacked, and she spent years during World War II rolling bandages and doing whatever she could do to help our soldiers during World War II. So she was turning 100, and we reached out to Charlie and asked him if he would come and give our group an update on what was going on with the medical liability situation in Pennsylvania, and if he could get a proclamation from the Pennsylvania Senate congratulating Norma Newhart on her 100th birthday. And so it was a beautiful September morning that we all got together at a member's house for Norma's birthday party, and on the way to that meeting, I heard that a plane had flown into one of the World Trade Towers. It was September 11th. Instead of leaving to go be with his family, as we urged Charlie to do, because one of his cousins worked in the World Trade Towers, he stayed so that he wouldn't disappoint that very sweet little old lady, who incidentally, after Charlie presented her with the proclamation, said, "I've never been this close to a senator before, especially such a good-looking one." And Charlie turned bright red, like he is right now. He did what he promised us he would do. Then he went and found out that his cousin had indeed escaped and was okay. Then he came back and had a piece of birthday cake with us. And that's kind of the Charlie Dent that I like for people to know, because we can all read the nuts and bolts. But there is a very committed, compassionate person who is he's very easy to reach out to. If you've got a question about anything, you can reach out to Charlie's office, and they'll see to it that you get an answer. But Charlie has a very special relationship with doctors and HealthCare in Pennsylvania, which is why we asked Charlie to come to this event. And it is my honor to introduce to you our Congressman from the 15th Congressional District, Charlie Dent.
Thanks, Donna, for that. Thank you for that very kind introduction. That's a true story from 9/11. But Donna didn't tell you is before I walked in, I did make some phone calls to inquire about my cousin. He was on the 91st floor, 91st floor of the North Tower. The plane entered 92 to 90, somewhere between 92 and 94, and he was on the highest floor of the people who escaped. Nobody above him got out of the building. And I remember that day because I had called before to find out, had no status. And after we did the presentation, I called again, and my brother called me back and said, "We don't have details, but he's okay." And then you came back in for bumped and bruised, but he's okay. And so I'll fill you in on that after class here. But thank you all for coming out tonight to talk about the HealthCare law. There's so much to say, and I've been given a fixed amount of time. I know you're going to hear from Dr. DiPolito in fairly short order. Also, Christine, thank you for helping put this together as well, along with Donna. And Donna has been a real force on the issue of HealthCare for some time, has been in contact with me over the years on any number of issues as it relates to good HealthCare policy, both at the state and federal level. So thank you, Donna, for staying at this issue all this time. And by the way, you should all know her husband, Peter. Hopefully you'll never need his services, but if you do, you want to talk to him. Finally, I'll say this too. It's true, we've worked a lot with physicians over the years in the medical community. My daughter is now a freshman at Penn State in pre-medicine, and so very excited. Actually chemistry, but with a medical track, so we're excited for her. But a few things about the HealthCare law that might be of interest to you, and then you can interrupt me at some point, and I'll stop, and you can start asking questions. But this HealthCare law, It's a challenge for a number of reasons. One, it's going to drive up cost. Two, it's certainly going to disrupt coverages. Three, it will also stifle medical innovation. Four, it's going to destroy jobs. And this is just not, these aren't simply opinions. I can back up these statements with a number of folks who've done some estimates. For example, just the cost of the law alone is estimated to be at $1.8 trillion over 10 years. And that's almost double what was the original estimate, at about $938 billion. So when the law was passed, the estimate was $938 billion. This is really for the entitlement side of this. $938 billion, that estimate has been doubled fairly recently, actually. So from 20, it's an incredible estimate. That comes from the Congressional Budget Office, by the way. They doubled their estimate since the law was enacted. Also, I'll tell you too, the cost of insurance. The president promised that insurance premiums would go down by $2,500. Truth is, they've actually gone up by almost $2,500. That's from 2008, $12,680 in 2008 to $15,073 in 2011. That's according to Kaiser data. Also, the individual market. We expect premiums on the individual market to increase by an additional $2,100 per family. The Medicaid expansion, that is going to be borne by, will have a significant cost to the states. That cost will be about $118 billion. Now, of course, the Supreme Court ruled recently. The Supreme Court ruled recently on the law. They upheld the law, stating that the individual mandate was really not so much a penalty but a tax. And so they upheld that. But what they did do on the Medicaid piece, they said the states could opt out of the Medicaid expansion. States are permitted to opt out of the Medicaid expansion. So that will ultimately, at some point, will reduce the cost of the law, but will also reduce the coverage expansion. So that's also that's something also just to keep in mind. So when you look at what's happened in the law, it's essentially cut Medicare by about $716 billion over 10 years. The estimate at the time was about $500 billion, but that's been updated by the Congressional Budget Office, $716 billion. That happened in the last several weeks. So that's something, but basically cut Medicare to expand Medicaid. That's what's largely happened here. That's how the coverages will be expanded. Now, I see my good friend Ryan McKenzie, state representatives here, and as a state legislator, he's going to have to deal with the Medicaid expansion at some point. Now, Medicaid, right now, it's, and for those who are physicians in the room, a lot of physicians who operate on their own, practice on their own, really take very little, limit their Medicaid patients. They don't take much. So people who are on Medicaid today may have coverage, but they don't have very good access to health care. And the outcomes for Medicaid patients, the health care outcomes, tend to be pretty abysmal when compared to other people who are covered by either private insurance or Medicare or some other coverage. And that's something to keep in mind, but much of the expansion is born through Medicaid. Again, a coverage that does not have the best health care outcomes by any stretch of the imagination. So I want to at least make that point about the cost. Cost of insurance will go up. Cost of the states goes up. And certainly the taxes, all the various taxes in here too. Now I'll just point out the medical device tax, which is kind of emblematic of the health care law, the trifecta. Higher costs, less innovation, and fewer jobs. I mean, that tax alone, well, it's estimated, the industry says they're going to lose over 40,000 jobs just on that 2.3% tax on medical devices, bedpans, wheelchairs, prosthetic limbs, probe scopes, anything you see in a doctor's office, tongue depressors. These issues are very real, very real. And of course, this area is a big medical device area, but that's the trifecta. Higher costs, fewer jobs, and there'll be less innovation. You're going to take it right out of the innovation budgets in many cases. In the small companies, Boas Surgical right over here in Allentown, it's It's a 100-year-old company. They make prosthetic limbs, many for troops who've returned without them from Iraq or Afghanistan. And the owner of the company said that if that tax takes effect, his 100-year-old business is going to shut down. And nearly 50 people that work there are going to be out of work. But that's true of many of the device manufacturers. They tend to be small companies, and they're taxed on a gross. But those who proposed the law said that this would not affect costs. Well, if you're going to raise the price of everything in a doctor's office or a hospital, and they buy, of course, somebody's going to eat this. And that's something that we need to point out. So again, I just wanted to at least throw that one out there for your consideration. Disrupting coverages. Again, when you look at the incentives in the law, look at them very closely. If you're an employer and you have more than 50 people and you're not providing health care coverage, essentially the way the law works is that you'll be required to pay, either provide the coverage, or you'll pay a $2,000 per employee penalty after the first 30 employees. So let's say you have 90 employees. You will be required to pay for health care benefits for those 60. So the first 30 you can subtract, and then for 60. Now if you don't provide them, then you pay a $2,000 penalty per employee. So 60 times 2,000, and that's your number. Okay. Now the problem with this whole issue is this. There are many employers who are providing benefits to their employees that have more than 50 people. And by putting in a $2,000 per employee penalty, we've just given them all a big incentive to cancel health benefits and dump the employees, their workers, into an exchange. It's cheaper to pay $2,000 than to provide coverage to an individual or a family. That's the incentive of the law. And tens of millions of Americans are going to have their coverages disrupted. So when the president would say, if you like your coverage, you can keep it, my response is, well, not if your employer cancels your coverage. I mean, that's the reality. And at $2,000, that's not going to pay for the policy. So the difference has to be made up by someone. So that's why I said this does disrupt coverage. That's the employer mandate, not the individual mandate, the employer mandate that is currently in the law. So again, something to think about as we discuss this. And again, many people's expansion of coverage will be born through Medicaid. I don't know a lot of people who like to volunteer to sign up for Medicaid for their basic health care coverage. It's just, again, the outcomes are not as great, and their access to health care is often much more limited because of the way Medicaid reimburses providers, doctors, and hospitals. So just wanted to throw that out there too. On the job loss, the Congressional Budget Office now estimates that the labor force will be reduced by 800,000 workers by 2021 as a result of the law. Again, I would say for a variety of reasons, not the least of which are the taxes. I mentioned the device tax. Now, this one industry says that's 40,000 jobs, devices. And around here, by the way, just think of those devices. Olympus, Vibron. I mentioned Boaz Surgical, Precision Medical up in Northampton, and there are a lot of other little companies. One out in Upper Macungie Township that makes these very sophisticated bandages. That's doing rather well, but small and startup, and they're all going to be impacted. And there are many others out there. So I just wanted to throw that one out there too. So they're saying 800,000 jobs plus the employer mandate. What will happen is if the employers are now going to be required to provide the coverages, and if they don't have the money to do it, what they'll do is they'll cut their payrolls. They'll reduce payrolls to comply with the law. So what if the guy says, okay, I've got 100 people, I can't afford to provide coverage for 70, but I could probably do 50 or 60. Well, guess what? That means there are going to be 10 or 20 people put out of work, or they'll reduce hours and make people part-time, so there'll be less work for individuals. That's how you get that. I'm sure I didn't look at the methodology the Congressional Budget Office used to come up with an 800,000 person job loss, but I think that's a part of it. That's part of the calculation that went into it. Also, again, the taxes are substantial. There are over 20 new or higher taxes in the health care law, some of which are going to have, obviously, a negative effect on job creation in the country. So that's something I just wanted to throw out there as well. So the job piece. And again, the innovation. One of the beautiful things about the American healthcare system is that I always felt that our system, despite it's the inequitable access to our system and the problems and the high cost, it tends to be a very high quality system, a point of the spear, so to speak. A lot of great medical innovation occurs in this country. That's why one statistic people don't often talk about is the number of expatriate physicians who come to the United States to practice healthcare, practice medicine. They come here for a reason, because this is the place they can really advance their skills and their trade, and they a very big part of it. So a lot of the great advances in healthcare, whether it's on devices, pharmaceutical drugs, or whatever, a lot of that occurs in the United States, and there's a great deal of concern that if we move in, if this system is ultimately adopted and fully implemented, that one of the larger casualties will be medical innovation in the United States. And then the question will be, where will the next round of medical innovation come from? What part of the world? Where will this move? I suspect it will be China. I don't know. India. In fact, well, you're seeing all this concierge medicine. A lot of people are going to India for various procedures now. It's something to talk about. I also wanted to focus a little bit too on the Medicare issue. There's been a lot in the press about that. I mentioned that the healthcare law cuts Medicare by, it's really more of a raid than anything else, Medicare by about $716 billion. And some people said, well, it's all coming out of Medicare Advantage. Well, yeah, about $156 billion of it is. And again, I'm still operating off of the old 500 and some billion dollar number, but we had broken down. Hospital services were being cut by $260 billion, skilled nursing $39 billion, hospice care $17 billion, home health $66 billion, $33 billion from other services. And so I just wanted to at least say that those are many of the big cuts to Medicare, which many of the folks at the Congressional Budget Office and elsewhere have said that those cuts are not going to be sustainable. The bottom line is this. The folks who drafted this law, I think they knew what they were doing. Believe it or not, on many of these aspects, on many of these provisions, they knew what they were doing. Many of these tax provisions are not going to be sustainable, nor will many of the Medicare changes and cuts. And my fear has been that you heard at the time it was widely quoted because the CBO, people were quoting the CBO. They said, if you were to repeal this law, the deficit would go up. If you repeal the law, the deficit would go up. Now, if you believe that, you'll believe anything. But that's the truth is. And the CBO said that not because they're dishonest people, but because they had to make a lot of assumptions, and many of them are very bad assumptions. And they had to make them. And I understand the assumptions they made, but they also are quite aware that many of the Medicare changes, they can't predict what a future Congress will do, but I can. And I'll tell you, a future Congress will work to repeal many of the Medicare cuts, to unwind many of the tax increases in the bill. And so all these so-called pay-fors, many of them will be watered down, some of them will be eliminated, but the entitlement will remain. The deficits will explode, costs will go up. I mean, this is what is inevitably going to happen, unless the law is repealed outright and then replaced with I think more sensible reforms. But at least I wanted to at least share that with you about the nature of the law. In fact, the implementation dates. I mean, I don't want to. Maybe we could get the implementation dates, but various provisions of this law take effect at different times. Specifically, one of the more controversial taxes in the law is the Cadillac tax on healthcare policies. Many people in unions, for example, have very good healthcare programs, and they would be deemed a Cadillac program and therefore subjected to this tax. That provision does not take effect until 2018. 2 years after President Obama's second term would end, should he be reelected. Why is that? Well, again, many of the unions that support the law are going to work round the clock to repeal that provision. They're going to work round the clock to repeal that provision. And the president knew it was quite controversial, and that gives him time to mobilize and work to repeal it. And so again, but that's part of what's gone into the law that I think is very, very troubling. And also too, for the first time, there's a tax in here too they raised the hospital insurance tax, the Medicare tax by 0.9%. It's on the payroll tax, and they also threw in a 3.8% tax on investment income as well. I mean, that's tax on capital gains, dividends, unearned income for some taxpayers. That's also in there too, and that money's not going for Medicare, by the way. That's going to pay for the new entitlement program. That wage tax you pay, that payroll tax that you pay for Social Security and Medicare is dedicated. Most of it to Social Security, and a portion of it to Medicare. But some of this money will be taken out of Medicare and used for other purposes. So that's something I just wanted to at least put out there before you. And there's some other issues too that I want to get into very, very briefly, and then talk a little bit about I think things we can do to help provide for a better system and enact reforms that I think people will respect and that people will happily accept. First, the biggest challenge with healthcare in the United States is cost. Cost is what keeps most people up at night. Healthcare is too expensive. Problem with the law, again, it raises costs. It doesn't lower them. So what we should be doing is addressing the cost drivers. And there are ways to deal with this. First, and Donna and I have talked about this many times. We can mention medical liability reform. Now, that by itself is not going to solve the problem, but it is an important piece. We're not simply talking about what Dr. DiPolito and his colleagues pay for medical liability insurance. Sure, they pay too much, but because of the culture of defensive medicine, where many providers, practitioners, doctors are rendering services that are unnecessary, but they're being rendered simply out of fear of lawsuit, this is adding substantial cost to the healthcare system. So there are substantial reforms. And by the way, we did pass a very strong medical liability bill this year, and we tied it right to the repeal of the IPAB, the Independent Payment Advisory Board. The other little provision I forgot to mention, which is the 15 unelected bureaucrats, who will basically make very strong determinations as to what services will be necessary and what will not be. But their only real way to control costs is to reduce payments to doctors and other providers. That's what they're going to do. They're going to, when there's not enough money available, they're just going to ratchet down those payments. And so the fear then becomes, I'm going to get ahead of myself. We'll get back to that a little later. But what that will do to the healthcare system, I think it'll move us to a two-tiered system. A lot of providers are not going to take public. They're going to limit their Medicare payments or patients, and so they're going to be dealing more with private pay, and they'll just opt out of Medicare altogether. That's a big fear that we have right now. It's already a trend, and we're fearful that it will get worse because of what we believe this Independent Payment Advisory Board, I like to call them the medical IRS, what they may do. So essentially, we need to do that. We need to deal with medical liability cost driver. We need to give small businesses the same type of ability to purchase insurance the way larger employers do. Many larger employers are self-insured. Sure, the city of Bethlem self-insured, Lehigh University, Air Products, PPL, they're all self-insured. Why are they self-insured? Well, because they want to get out from under the state insurance mandates, the state regulatory ambit. And so they operate under this, under ERISA, it's a federal system. They basically escape state mandates, and they tailor their insurance product, their health insurance, to their employees. Now, it's their money. Let me be very clear about it. It's their money. So in other words, I see Dave back there at PPL. PPL pays they pay the premiums. They assume all the risk. They may hire Blue Cross or Highmark or Aetna or somebody to administer this program for them, but make no mistake, PPL is the insurance company. They're paying an administrator. And they've done this, and many of the larger companies and many of the folks who are self-insured tend to have pretty good plans. They're pretty good health care plans, by and large. And so they tailor that for a specific reason. And again, they get out from under all the various state mandates. Smaller employers don't have that opportunity. We should give smaller employers the ability to pool together, realize the same discounts, let them also reach across state lines. So a group of, I'll pick, let's pick the Asian Hotel Owners Association, the National Association. Many of them own smaller hotels, some larger. Why can't they pool together, or a group of home builders, or whatever it is, pick your favorite organization, let them pool together and let them try to self-insure, assume the risk, just like a larger company does. That's something we could do. I think that would be very, very helpful, and they will shop, and they will be they'll be very smart about this. Also, let's level the tax playing field. When an individual buys health insurance, they have to use after-tax dollars to do that. Why don't we give the individual the same type of tax treatment that the company gets when it buys insurance for its employees? Level the tax playing field, or equalize that system as best we can. Also do it for the self-employed. Another thing we can do too, for lower income families and defray the costs, is set up refundable tax credits. It's money coming back to help them purchase affordable insurance. I think ultimately we're going to be moving in the direction of lower premium, higher deductible plans, married to catastrophic coverages, through health savings accounts, flexible spending accounts. That's something we can do. Now for the other issue too, and everybody here I think would agree that we need to deal with individuals who have pre-existing conditions and cannot get coverage. We all know that's a problem, a big problem, and it needs to be addressed. And there are ways to deal with it. What we should do is we should supplement the states. 34 states already have high-risk pools. The last I checked, it was over 34. That was before the HealthCare law was enacted. There were 34. Some were fairly effective, others were not. We need to help strengthen those and essentially make sure that those who are the sickest among us have access to coverage. I often say, think of it like I hate to use the auto insurance analogy because it's not always the best, but if you think about it, there are people who cannot buy auto insurance because they've had a lot of accidents, and so they go into the state insurance fund. So think for a moment that, okay, there's a person who's very ill, and they may have the money. In some cases, they may have the money to purchase insurance, but nobody will write it for them. So we have to make sure they have a place to go. And if they can't afford the insurance, then you subsidize that individual. And there are ways you can do this with a reinsurance model. That's how we should move forward, and also allow for greater portability. So if a person does have health issues and does want to change jobs, that they can port their coverage from one employer to the next. I mean, those are the issues that we ought to be dealing with. Just expanding portability protections would do a lot to help many people. So that's something I just wanted to really focus on as well. Another thing we're going to have to confront too, the way we pay providers, and I started talking about that a few moments ago. These physicians and hospitals and others, especially these physicians, they get paid by Medicare, and we have to talk about the cost shift within healthcare. We all understand the cost shift. If somebody shows up at St. Luke's here in Fountain Hill without coverage and they go into the emergency room, they're treated. We all understand how that cost is shifted to those of us who pay. But there's also cost shifts from Medicare and Medicaid. Medicaid especially notoriously underpays. I mean, I don't know, Dr. DiPolito, what would you say on average you get paid on a Medicare patient on a dollar?
Medical assistance.
Yeah, medical assistance. Medicaid. I'm sorry.
Medicaid. I admitted the patient to the hospital for diverticulitis. Paid me $17 for the visit.
And what would have cost you to treat somebody else?
It cost me more than gas just to get there.
Yeah, so it's
essentially Medicaid pays 1/3 of what
so
commercial insurance.
On a good day, it's paying 33 cents in the dollar. On a good day.
That's on a good day.
I've heard numbers lower. Medicare, I'll say on a very good day, it pays 80 cents in the dollar. Usually pays less than that. So the point is, there is a cost shift in healthcare from the public systems to private insurance. Those people who are paying private insurance, in part, their premiums are higher for all these reasons. And that's something we are going to confront. And if the healthcare law is enacted and implemented, and the Independent Payment Advisory Board says, oh, geez, we don't have enough money for everybody, they're going to start ratcheting down payments. That's the mechanism they have at their disposal to control cost. They'll lower the payments. So what will happen is, today, according to the AMA, American Medical Association, 1/3 of primary care physicians are limiting their Medicare patients. They're limiting. This is going to get worse. So if they tell Dr. DiPolito or one of his colleagues that instead of whatever a hip replacement costs, we're going to pay you, instead of paying you $2,000, we're going to pay you out of Medicare, we're going to pay you $1,500. they're going to limit the number of hip replacements they'll do from Medicare. Or in some cases, they'll just stop taking it altogether. And that's my fear. And you'll end up with a two-tier system of care. Those who will be in the public systems and those who are going to have the ability to go outside the public systems. And you'll have physicians just dealing with private pay and others dealing with the government paid systems. And so this is a problem that we are going to have to confront. This is going to get even more challenging because when you look at, and we cannot separate this healthcare law from the broader fiscal challenge facing this country. Anyone who reads knows that this country's long-term liabilities exceed our capacity to pay for them. Right? If anybody doesn't believe that, you know, I don't know. Go take a good look at Europe and maybe clarify this situation. But the truth is, in the healthcare programs alone, and not just Medicare, Medicaid, but new healthcare entitlement, the federal healthcare programs are literally going to consume all revenues coming into the federal treasury within about 20 years. Everything. Everything. You know, and so that's how big the issue is. And so that's why we have to enact reforms that are going to help drive costs in the opposite direction, short of the blunt instrument of a harsh price control, which will move you right into a two-tier system, maybe a three-tier system. So something to think about. In fact, I just had a member of Parliament tracking me. He was from Wales, Bangor, Wales, by the way, for which Bangor, Pennsylvania was named. And we were visiting here, and he told me that their National Health Ministry in the UK is the provider of health services. And over there, the National Health Ministry is when I say that, they own all the hospitals, all the doctors, they own all the pharmacies. It's a totally government-owned and operated system. It's the third largest bureaucracy in the world. This is a nation of 62 million people. You know what the other two larger bureaucratic organizations are in this world? Chinese Army and the Indian Rail Service. Each of those countries has more than 1 billion people. And so think about it. I mean, that's the UK. Just a fun little fact. But the point is that it's a real issue. So rather than me go on about this law and what's in it and what's not in it, there's so much in here. We could go on all night about this. But at least I wanted to point it out to you that I think at some point, we're going to have to come to grips with this. When you look at our long-term obligations, we're already on an unsustainable fiscal track. This law compounds the problem significantly. And so we have a challenge before us, and we're going to have to confront it. And if people ask, is it going to be repealed? I said, I don't know. There's going to be an election in a few weeks, 2 months. And that's largely going to determine whether or not that may be the fact that determines whether or not this law is repealed and then replaced. Wayne?
With medical assistance, that's actually a generous comment. I mean, if I see a patient in the hospital on a consult, I don't get paid anything. The medical assistance will pay the attending physician, and they'll pay them for seeing the patients. Any consultant, whether a cardiologist, a rehab physician, they get zero. If you're the first consultant, I think you get paid like that nominal fee, and they only get paid once. And if you see them, if they're in a hospital, if you see them 4 times, 10 times, you don't get paid anything. So I mean, I basically treat medical assistance as basically no insurance, and that's my,
So uncompensated care.
Uncompensated care. That's what medical assistance is. The fear is if medical assistance, another 30 million people in this country get medical assistance, I mean, providers are not going to be able to afford to care for these patients, and the access is going to be much worse than it is. And that's why providers don't provide care for medical assistance. They do in the hospital because, they're in the hospital, they want to take care of patients, and they see patients, and they need to do that. When they're in the office, and whether you want to see an orthopedic surgeon or any outpatient physician, whatever, they're not going to take them because no one could afford to work for free. I mean, you could afford to some extent, and that's only made up by the fact that people do have private insurance, and you're being paid, and from other insurance companies to see other patients. If that amount increases even dramatically more, You know, physicians are businesses, you know, they have expenses, everything else goes up, they have to pay their own health insurance. And as you know, things are going up, and that's why physicians are joining hospitals. Hospitals are much better compensated by Medicare and medical assistance. I guess the hospital associations better than us physicians in terms of lobbying. And you know, I personally believe the way to treat healthcare, I agree, it's the cost, it's not the quality. And medical savings accounts increasing responsibility and people realizing what things are costing. I think low premium for basically treating insurance like any other insurance. Hopefully you won't need it for higher, lower, for higher deductibles, and basically using medical savings accounts that build up over years that are tax deductible accounts that use only for health care to allow you pay for office visits, the $100 visit or whatever it is. And to use insurance is the way insurance was meant to be, for things that you hope you'll never have to use, for catastrophic illness, high deductible. So if you are hospitalized, have surgical procedures, those things are covered. The way things are going, people are taking less responsibility. If you take less responsibility of what you do and what you pay for, things are going to cost more. We all go to, to get our car serviced. We have to go to the gas station. We shop around, right? Well, you have no idea what things cost. And what the charges are, what the hospital charges or what a physician charges, have nothing to do with what we get paid. I think those charges should go away. Personally, I think those charges make more sense. Then you have a poor individual who has no insurance, goes to the hospital, has no insurance. They get these astronomical bills that are based on charges. I mean, that's also ridiculous. I mean, any charges and what someone gets actually paid should be the same. I mean, there should be reasonable amounts. And by taking more and more out of personal responsibility in this healthcare law, I mean, I can't imagine this thing is going to decrease costs. I mean, there's just no way. I mean, it makes no sense. So I also believe in, again, high deductible, low premiums. Now, insurance companies have to take a role here too. I mean, they can't keep on pocketing money, increasing premiums, and not giving us more, but giving us less. I mean, and no one's really talking about that. And I'm not protecting the insurance companies by any means.
Dr. Dubov, what are you doing on October 3rd?
I don't know. It's my
Could
daughter's
you
birthday.
come here and be one of our speakers on October 3rd?
I improvise. I don't.
You can improvise.
Maybe I'll just come. I don't want.
That's why people buy supplemental insurance to
Exactly.
pay for what Medicare, does not.
But
Yeah.
you get rid of some of the advantage and some of the people that are using that system to help because they need subsidies for the coverage. They're all being cut out of that now, so that's, you're going to put more and more Medicare people into Medicaid situations.
Well, see, that's the answer that the president and the proponents of the healthcare law will say, that we're not actually cutting benefits.
Yeah.
Well, if you simply cut what you're going to pay the people providing the services, these people are not going to be able to take advantage of the benefits. They won't be able to take advantage of it. It's that simple, or at least many of them will not be able to. And you're going to have people opting out. I mean, my fear is that Medicare, which I support strongly, Medicare will look like Medicaid. That Medicare will start paying out the same way Medicaid does. And I don't think the senior population in this country will stand for it. Because they're not going to be able to get in and get the access they need to the physicians they need. So I mean, that's the harsh reality here. So they say they're not cutting benefits. It's sort of disingenuous. I mean, if you're not going to pay people to provide services, you're not going to get the benefits. So, Bill, then I'll come back over here. Okay.
Is there a 3.5% tax on house sales starting in 2013?
Yeah, I mentioned that 3.8%. I mentioned that 3.8% tax on unearned income, dividends, capital gains. It comes there for, I guess that would be for an asset over 200 for an individual, 250 for a couple. So yes, it would hit a residential sale.
Well, and also, is there a 1% tax on bank transactions and everything
No.
else? That's not.
No, there's a bill. There's a bill out there introduced by Jacques Fatah of Philadelphia. He basically scraps the whole tax code and replaces it with a 1% tax on all financial transactions. And I have a bad idea file, and really big. That's it. That's it. But that's it. So that's not part of the healthcare law. So yeah.
I don't know. You know, I have 2 children that on their recent tax returns, they're self-employed, and it just seems strange that both of them have gotten audited, and we're talking in 2 different sections of the country by the IRS. Back to 2009. Wow. So I got a feeling that this is already starting as far as trying to build up some sort of back taxes. Fortunately, my son already beat them, and my daughter's in the process of trying to get out from under. But my question though is, I have individual insurance. I do not work for an employer that provides insurance.
You buy in the individual market then?
Right. How is this going to affect me?
Well, I said earlier, we had data showing that the premiums for those in the individual market are going way up.
And if you can't
They're going
afford
way
it?
up. I mean, that's the reality. The individual market, that was supposed to be by, I have the actual number here, it was supposed to be by, oh my, I'll give you that number in a moment. Oh yeah, the CBO found that the healthcare law's new insurance mandates will raise premiums on the individual market by an additional $2,100 per family. The CBO, I mean, in the individual market, somebody like you who's just going to go out there as an individual going out trying to buy insurance. That's their assessment. So again, this is driving costs up,
Right.
not down.
And
And
if I can't afford it, can't afford that?
well, you get in the exchange, you get subsidized, and you know, I mean that's.
And what
before you're
happens if
60
somebody is making a little too much to get into the exchange?
Well, that's
because
another,
of course they're all going to have the salary.
Well, here's another. Okay, you're raising a point. I mentioned the employer mandate.
Right.
That if an employer did not provide benefits in a company over 50 health benefits over in a company over 50 employees, they would pay a $2,000 per employee penalty. There's also provision too that you could end up paying a $3,000 penalty if you know, if you were providing some level of benefits but they weren't qualified. It's very complicated. Also, for small businesses, fewer than 25 employees in the law, there are subsidies available. But your workers have to be making less than a certain amount to be eligible. The truth is, very few businesses with whom I have spoken are taking advantage of that. Very few across the country are eligible to take advantage of these subsidies for small businesses, you know, who are trying to provide health insurance. I mean, unfortunately, the law, you know, it gives incentives for people to keep their companies smaller, not larger. You know, don't get over the 50-person threshold. You know, avoid the mandates. I mean, again, we're trying to grow the economy. One of the challenges in this country right now is our economic growth rate is at 1.5%. You know, our job growth is not keeping pace with population growth. That's why the unemployment rate's not dropping significantly. It's not dropping because we have to grow this economy. And if this law is going to slow economic growth, and when federal spending is at 24% of the economy, or GDP, as we say, gross domestic product, that by historic standards is high. We usually have been around 20%. That's where our federal spending has been as a percentage of the economy. And for each percentage of increase in federal spending as a percentage of the economy, we can measure how much less growth in the economy we'll see. We can measure it. It's empirical. I mean, and so we have to get that spending level back to where the post-World War II norm has been. And again, that's where it was during Clinton and Bush. And
would Chester Vanderpool please come to the front desk? Chester Vanderpool.
So we have to have these kinds of discussions. And another thing too about the law that I guess has been troubling to me, you know, there are a lot of gimmicks in the law. And I think you expect a fact-based, truthful conversation about what's happening here. I mean, there was one provision in the law called the Class Act. It was a long-term insurance program essentially, and I think the cost estimate was $80 billion. But this is a gimmick. They were taking the premiums that were going to be paid for the Class Act, and they were using that to pay for the new HealthCare entitlement, right? And then after 10 years, so when the Congressional Budget Office had to count this, and they knew this was in it, but they had to score it based on the 10-year window. And they looked at this, okay, here's 80 billion in premiums, I think it was 80 billion. And they said, and this is gonna be used to pay for the entitlement, but the problem was that same 80 billion was supposed to be used to pay for the benefits for those who were gonna be needing a long-term care service. So they double counted it. It was a gimmick. I mean, and of course, and we said it at the time, the law was being run through the Congress, it was being, rammed through. We said, this is a problem. It's going to be a big problem. It's never going to work. The program is going to be insolvent the moment you have to pay out a premium, have to pay out on a policy. And then what they did, then Kathleen Sebelius, Secretary of HHS, about 6-8 months ago, maybe it was a year ago, she acknowledged this. Yeah, we're not going to implement the Class Act. Okay. There's the 1099 provision. We actually repealed that piece. The 1099 provision, any employer, that was that $600, it was an accounting nightmare. It was a paperwork nightmare. It was a $17 billion hit. I won't get into it. It was an accounting nightmare. Every accountant in the country was, felt like their hair was set on fire. They were so upset about this, and we had to repeal it because it was just going to be an administrative nightmare for everybody. But there are provisions like that in there too that were just not workable, could never be implemented. So there was. I saw a few more questions. Let me go back. Ma'am, okay, you like to go back now?
But in reference to that woman's question about what if she can't afford any insurance, what options are there out there for her? Because I'm kind of in the same boat.
Yeah.
I had to drop my insurance in November because I couldn't afford it anymore. And right now I'm paying $420 a month for my children, and they're on shift. And I'm still paying that much a month. And I can't have insurance because I'm using all my money to pay for my children. What can we do?
Well, I think and I think Dr. Dubov stated it fairly well. We have to make sure that when you buy insurance, and we should make sure that you have access to a low premium, high deductible plan married to a catastrophic coverage. Right. That's what health insurance is for.
But they don't give us that.
Well,
I tried to get that, and I couldn't get it.
And it's true, and it's not. And my fear too. I mean, there are.
And I've been rejected by one other insurance company because of a condition I have, and it's not a life-threatening condition. In fact, a lot of women, 70% of the women in the United States have it. It's called fibroids. They go away after menopause, and Aetna rejected my plea to buy insurance because I had fibroids. You believe that?
That's incredible.
Yeah.
Well, a couple things too. Well, like I said, I think that at the end of the day, we have to equalize the tax treatment, give you an incentive to purchase, but also a product that is affordable. And
right.
and there are some out there, believe it or not. I mean, they're not always easy to find, but there are some that do help with that lower premium situation, high deductible, catastrophic coverage. And Nancy kind of sells some of this stuff, actually.
Yeah, I used to. I'm not in health insurance anymore. So, but actually, the problem with those plans right now is they're not rated according, like the high deductible. You get a $10,000 high deductible plan or something like that. It's not rated fairly or against as far as your benefits go, and you're still paying too much premium for it. Let's put it that way. Yeah, and that's something that really needs to be addressed, both by, I think, if the government started looking at those things instead of looking at trying to cover everybody's payment and made it more affordable.
I want to say one thing too about the cost of health care and Medicare. You're hearing a lot of debate about Medicare and the future of health care generally. And I mean, you look at the Medicare program today, and when it was first established in 1965, there are estimates made as to what the program would cost. Well, the program cost 10 times more than was originally projected for a whole variety of reasons. We're living longer, better medical procedures, more technology, better prescription drugs, all sorts of reasons that they probably weren't able to account for back in 1965. And so the cost has gone up. And of course, and it gets into the way it's structured, the Medicare A and B, the hospital and the doctor provisions. But you look at Medicare Part D as in drug, That was established in 2003 before I came to Congress. Interestingly enough, that program has come in 40% below cost projections. It's different than traditional Medicare, A and B. Why? Because they figured that then when they structured the law, they said, rather than having the federal government, CMS, Centers for Medicare and Medicaid Services, dictate prices for drugs, just set the price, like a price control, or have the government negotiate the price, they said what we'll do instead, we will have the plans, and there are going to be a whole bunch of plans. They're essentially insurance companies, insurance plans, and they will negotiate directly against the drug companies for best price. Now, say what you will about insurance companies. They are not gentle, tender negotiators. And they beat the drug companies down in price. So the cost of the federal government has been 40% below projected, as well as to the patient, or to the senior. Their costs are lower. Well, that's a model. That's actually a premium support model. And so, but it doesn't pay first and last dollar coverage for everybody who's getting prescription drugs. The sicker and the poorer get more assistance. If you're very low income, you get much more coverage. If you have catastrophic costs, you get much more benefits. If you have more modest costs, you get less. And you're basically paying an insurance premium, everybody. And there's an 80% patient satisfaction rate with the program. That's a model. You know, that's often being discussed for Medicare for the next generation, which is very contentious. You know, Paul Ryan and all that. That's the model that's being discussed. And for the next generation, not for those who are currently on it or those who are nearly on it. Because right now in Medicare, 10,000 individuals a day, baby boomers, are going on Medicare. There will be 15 million over the next decade getting on Medicare. And by the way, the program goes insolvent in 8 to 12 years. If you believe the Medicare trustees, it's 12 years. If you believe the CBO, it's 8 years. Either way, it's going insolvent. And it's predictable. So this is saying that there are some ideas out there that can help us control costs in a way that you will respond to better than the blunt instrument of a price control. It's something that we really have to have a very deep conversation about this in this country, about how to structure those programs. I think there's a way to do it, and we have actually a fairly bright future. But the issue but the fundamental debate, and I think it'll be played out in this election cycle, certainly at the presidential level, is going to be what kind of a system do we want? One with greater government control and price controls, or one that's going to be more reliant on choice and competition. I mean, these are the two choices, and I think the election is going to determine which path we're going to take.
Well, I heard that the insurance companies are going to be forced to pay back the patients if they don't use 50% of their yearly premium.
I think you're talking about the medical loss ratio. I think you're talking about a medical loss ratio.
Yeah.
It's 80%.
It's 80%.
50 to 80%.
It's 80%. They have to use that to pay for benefits. Now,
yeah. The Secretary of Health and Human Services said last night that it was 50%.
No.
Well, I think it's 80%.
Yeah, it's 80%.
But here's the other issue too. Now, if you go to like the Bethlehem Y, you go there and the seniors have what's called silver sneakers. They go out there and they do things. They move around like a senior aerobics. I mean, but call it what you will. But it's a nice program. My mom does it at the Allentown Y. It's good fellowship. It encourages healthy activity for seniors. Programs like that, under that provision, the medical loss ratio, are going to go away because that's not being paid. They use insurance money. Oftentimes that's subsidized. The insurance companies are trying to encourage elders, to stay active.
But I'm thinking, like, I spend over $5,000 a year on my children's health care insurance, and I might take them to the doctors once each a year for their well visit, and maybe for some strep throat, a little ear infection. And I mean, is it really $5,000 worth of medical expenses? If it was out of my pocket, an office visit's like $125 out of my pocket. And those vaccines and stuff, I mean, I would be taking them to the doctors once a month for that $420.
That's why for that example, if you had medical savings accounts, which is not and carries year to year Right now it's 25, and which Obamacare wants to get rid of, if I'm not
Correct.
correct. All right? You would, and then there should be affordable high, and that's the problem. You need to force insurance companies to provide this. There should be affordable, high deductible thing, and then for those examples, if you're gonna spend $1,000 to see your doctors, right? That medical savings account, which is pre-taxed, and you get a tax deduction, that's been used. We need to have, there needs to be a true charge and cost of what something costs. It should be whatever it is, $100 to see a doctor's gonna spend, whatever that is.
But medical economics are so, they're so distorted because oftentimes, you often feel like, you're being charged what